Okay, so this is a little bit of a hodgepodge of topics we'll cover here, but we'll call this designing treatment regimens. So we'll talk a little bit about rational prescribing, kind of the steps you take when you're deciding who and what to use drugs for. We'll also talk a little bit about prescription writing. Have you guys covered anything with prescriptions yet? Fantastic. This will be your first exposure, hopefully the best exposure you'll get to it, right? You guys remember everything? No, probably not. Chances are you guys will never have to write a paper prescription in the actual clinical world. I had a doc who had just finished her pediatric fellowship, and we had our computer systems go down one night, and she's like, well, I need to write a prescription. And so I said, well, here's the paper. You can write your prescription on here. And she's like, I don't know how to write a prescription. Like, okay, here's how you do. Write your name, and then here's the drug. You know, it's just one of those things where it's like you guys might never have to do it, but it's good to know what needs to be on there. Needs to know that you're doing it correctly. So we'll kind of go over some of those things there. We'll talk about controlled substances as well. Everyone's favorite topic. Okay, so rational prescribing. So usually when you have a patient, you make some sort of diagnosis, right? So you guys are getting trained up on how to make the diagnosis, how to do the physical exams, how to read the tests and all those kind of things. But when it comes down to it, you need some sort of therapeutic management, right? In some cases, maybe do nothing, right? That's always a good one. It's really easy to be good at that, right? Some cases, maybe surgery. It could be radiation. It could be counseling. It could be health education. A lot of times, it's medication, right? Because everyone comes to the office, and what do they want to leave with? A prescription, right? They usually feel gypped if they don't come out with one, right? Whether it's appropriate or not. So this is most common, and again, most often is going to require a prescription. We'll talk about. So when a patient comes in for an office visit, about 2/3 of the time they're going to leave with a prescription, and about an average of 1 prescription per visit, right? So they see you multiple times a year, chances are they're probably going to come back with multiple scripts. And so we'll see that you need to follow a rational approach when you're deciding what to use, when to use it, and how to use it when it comes down to choosing to prescribe something for a patient. So step 1. Make your specific diagnosis, right? Patients oftentimes want you to do something that may not always be appropriate based on what they actually have, right? So again, if you write prescriptions just because the patient's hounding you for one, that's not doing anyone any favors, right, in the long run. It may help your patient satisfaction scores, which may be good for keeping a job, but it's not really good for the patient, right? Looking at that, unnecessary costs with filling prescriptions they don't need. Antimicrobial resistance is a huge thing. So overprescribing antibiotics is probably, if I had to guess, it's either going to be rogue artificial intelligence that takes out the human race or superbugs. Take bets on which one you think it's going to be first. But antimicrobial resistance is a huge problem due to overprescribing antibiotics. And then adverse drug reactions, like unnecessary reactions they're getting from these drugs, and they don't really need them in the first place. So, but again, you need a tentative diagnosis in a lot of cases to say, okay, here's what I think is going on. Here's what we're going to do. So, for instance, you have a patient, you said, coming in with joint pain, all this kind of stuff, seems like classic rheumatoid arthritis. You say, okay, I'm going to go ahead and share my diagnosis. I'm going to say why I think it's this versus something else to the patient. I think it's RA versus osteoarthritis for these number of reasons, right? So now you got your. So the next thing, you need to consider kind of what the pathophysiology is for the disease state, right? Because that will help you decide how we should treat this most appropriately. So for instance, knowing the difference between osteoarthritis versus rheumatoid, does anyone know the difference between the two? So yeah, so the joints are the big thing that are being affected here. Osteoarthritis is kind of what? It's just bone on bone, right? It's just wearing out the joint. You just use it too much for all your years. You played, some high school football, and now you just worn out the joint, and that's just bone on bone, right? Versus rheumatoid arthritis, which, anyone know what that is? Autoimmune condition, right? So you're actually attacking itself. The joints end up taking a big hit. So the joints look completely different. The manifestations are a lot different. And so based on that, you need to consider what type of drugs may be effective for that based on, or what type of treatment is going to be effective for RA versus something like osteoarthritis, right? And so, of course, you need to share that kind of information, say, hey, I think, the reason why you're having all this pain is because, all this inflammation is happening because your body can't tell itself from a foreign invader. And that's why all this is going on. I think my thing went off. And again, obviously, depending on the patient, depending on what their health literacy or their age is, you need to be able to communicate with them kind of effectively on that. And so there's lots of great resources online too, especially if you're prescribing medications, lots of resources for patient education. Oftentimes, especially being here in Florida, we have a lot of foreign-speaking patients, like especially Spanish is a big one. So if you're not fluent, you can print out Spanish-specific information for patients and have that available to them as well, which is a big helper. A lot of times, though, especially with us being a travel hub, we got a lot of patients, and of course, Nemours is right next to the airport. We got a lot of patients from South America, from Europe, from Asia, all kinds of different places coming into because they want to go to Disney. They want to see Mickey Mouse, of course, but they get sick and they come to us, right? So especially those Make-A-Wish kids. But basically, it's nice because you can have things like interpretive services. So we have this this iPad on a little stand that we can kind of take around with us, and you have a live interpreter that'll get on there. So if they speak Portuguese, they speak Swahili, whatever it happens to be, they can get on there and basically communicate appropriate with your patient, which is great. Right? It's not really nice when you have those kind of resources. So anyway, so then you want to figure out what your therapeutic objectives are going to be. So say, okay, well, based on the pathophys, these are the things I want to be able to treat with it. So for instance, with RA, we know it's an autoimmune condition, so we want to do things to deal with the inflammation that your body's developing against itself, and we would like to arrest the disease course, right? So you'll find that for certain disease states, you can't fix the problem, you can't necessarily reverse the damage that's done, but you can prevent it from getting worse, right? And so in these cases, in RA especially, this is something we'd want to do. And so based on these different goals, you're going to find that you may need different types of medications or different therapies in order to make this happen, right? So I'll show you an example of that in just a second. So in this case, you would be selecting your drug of choice. So again, it may be one or more groups depending on the therapeutic goals we've identified. And you should really take a lot of patient specifics into account when you're deciding what to use, right? So look at their age. What kind of disease states do they have? You know, do they have diabetes, which would make one type of drug class way worse for them than this other class? You know, look at other medications they're taking. All this you have to take into account. So, for example, with RA, one of the things you'll be treating them with is NSAIDs, like non-steroidal anti-inflammatory drugs. So, for instance, do they have a history of, say, aspirin intolerance because they developed GI ulcers, right? Or they have an allergy to aspirin. You know, so those are the kind of questions you ask. Well, maybe this type of drug is not the best for them. You know, is there a major cost problem, right? So, you know, based on anyone keeping up with the healthcare issues nowadays, you probably don't have time to do it. But anyway, it's a mess, right? So I don't care what side you fall on, it's a mess. So based on kind of what happens, you may find patients may have no insurance whatsoever, right? And so in a lot of cases, if you prescribe something, it doesn't matter if it's the best drug in the whole wide world, they can't afford it, they're never going to take it, right? So that's one of the things you have to consider, you know, what can they afford, what they can get a hold of. This is why you guys will learn, you know, especially if you're dealing with more like indigent populations especially, you know, what are the $4 lists? What are the free antibiotic options, or what are the free options they have at different pharmacies? And so you'll learn that kind of thing. You'll have a list available, and that will help you decide, in some cases, what to use. And then other things like, you know, is once daily dosing important? You know, does the patient have memory problems, or they have issues taking multiple medications multiple times a day? I don't know, is anyone like kind of familiar with the development of HIV treatment? But if you look back in, like, you know, say the early to mid 90s, these patients were taking dozens and dozens of pills multiple times a day just to stave off their disease state. Now sometimes they can get away with just one pill a day. So it's really kind of amazing how we've kind of made some advancements there, and you have to consider what's most important to your patient and making sure that adherence is good. So that's one of the things you can look at. So next you'll kind of determine the appropriate dosing regimen. So that'll be based on the kinetics of the drug. It'll be based on the organ impairment in the patient, if any. So you may need to alter the frequency, you may need to alter the dose to be appropriate for that particular patient. And then, you know, what is the patient going to tolerate? You know, are they going to be willing to take a drug multiple times a day? If not, then it's not going to work for them regardless, right? So adherence is super, super important. Next, you're going to look for a monitoring plan to figure out, you know, how is the drug's action working, how is the disease state progressing, and so you need to be able to describe to the patient, hey, here's the effects I'm looking for in the drug. Here are the things that will show that the drug is working. Also, things you would be testing from a lab standpoint, like here's the lab test we want to get, here's why we're testing these labs, you know. I'll never forget, I remember, this is probably not super related, but I remember one time I got a puppy. It was like my first puppy. I was you know, I was in fellowship, and I said, this is the time to get a puppy. And so, sure enough, like I was walking them one day and came back and just a ton of worms, you know, in the poop, and I was just like, this isn't good. So let me take them to the vet, right? So I took them to the vet, and you know, the vet tech or whatever came in, and was like, hey, we're gonna do this test, we're gonna do a CBC. And I was like, why do you want to do CBC? And like, cause it tells us if he's having, you know, if he's got an infection. I was like, I saw worms in his poop, I know he has an infection. Okay, we won't do that. Thanks. They're great. You know, so cut your cost down a little bit. So little things like that, like, you know, you share with them why you're getting a test done if it actually makes sense. So the puppy did fine afterwards. It did good. I know you guys are waiting for that resolution there. But anyway, and then you'll be able to explain like why you're prescribing this particular drug, you know, for instance, or the prescribed duration of use. So for instance, you know, like, you know, you give antibiotics to a patient who's, you know, comes in with a cold or something, or say, you know, sinusitis or, you know, cutotitis or something like that, and you say, okay, I want you to take this for 10 days. But they, you know, get home, they take it for 3 days, they start to feel better, and then what do? stop taking it, right? And so you have to explain to them, like, hey, you have to take it for the full 10 days because otherwise you can see resistant bugs come back. You may not kill the whole infection. So these are things you have to describe to them to make sure that they will be adherent, because you want them to be a partner with you, right? You're not just saying, like, I'm the provider, you're going to do what I say, because a lot of people don't want to hear that, right? They want to be active participants in their healthcare. So also, what would constitute a change in therapy? So for instance, if you're prescribing an antibiotic, you did a culture and you say, hey, if I give you a call back, the culture comes back and you're resistant for this particular antibiotic, then I'll give you a script for this other one, right? So kind of things like that. Or for instance, if you're on NSAIDs and you notice dark tarry stool, right? What could that be a sign of? GI bleed, upper GI bleed in particular, right? Because you're digesting all that nice hemoglobin and whatnot, so it comes out as a kind of dark tarry stool. So that would be a definite indication to come back in, right? Otherwise they may just see that and be like, well, I guess I'm getting older. I guess this is my stool now. Like, that probably isn't normal, right? So these are the kind of things you need to let them know, like, what's not normal, and just like, yeah, your body's just getting old, right? And then kind of get a plan for education for the patient. They need to be specific. They need to address things like age barriers, language barriers, educational barriers. A lot of patients are not going to have great health literacy, so you may be trying to talk to them, on even an adult-based level, and they are not even close to high school, right? So in some cases, you have to kind of bring things down to make sure that everyone's kind of on the same level as you. So for a good example of, using things like patient education materials, especially with lots of pictures, people respond well to pictures. Is enabled this drug called Diastat. You guys familiar with this drug at all? So it's a rectally administered gel, and it contains a drug called diazepam, or Valium is another brand name for that. So basically we give it rectally for seizures. So if you imagine being a parent, saying you have a child who develops seizures, and you're very freaked out by this in the first place. Now we hand you this drug and say, hey, next time they have a seizure, I want you to put this in their butt and give it to them. This will stop them from seizing. Like, how comfortable do you think you'd feel doing that? Not at all, right? So this is why good education happens, right? So in the ER, we'll sit there, we'll have lots of pictures with them, we'll say, here's what you want to do, the dose will already be set up as this, here's what you need to do, things like, it comes with a lubricant pack, right? A lot of people get so freaked out they forget the lubricant pack. That's not super comfortable, right? So those are little things you can kind of walk them, hey, when this happens, yeah, you're going to feel freaked out, here's what you do, step by step, and like have them repeat it back to you. Make sure that they can explain to you what they're going to do, when they're going to do it, and all these sort of things, so that way they know, that they know what you just said, right? Because a lot of times you can just talk to people and they may be getting so much information they just don't hear it, like kind of right now, right? But I try to ask questions so you guys can talk back to me, and that way we can at least make sure that we're kind of understanding one another. So same thing happens for patients as well. So again, don't assume. And the pharmacies, in a lot of places, you can ask for the pharmacist to counsel. When you go to pick up a prescription, what do they always ask you? You have a question for the pharmacist, and you can say, like, yeah, I have a question for the pharmacist, and you just hear someone go, because they're probably filling like 400 scripts or something, and that the one pharmacist is doing all of that, and they don't have a lot of time. So unfortunately, it's one of those things where it's like, yeah, they will take time out for you, but you don't always assume that they'll be able to do that, right? Which is why I like hospital pharmacy a lot better anyway. Actually, I went to a hospital because my second day working at retail is interning at a CVS and got held up at knife point. So I said, this is probably not for me. But that also, just you don't have enough time for kind of good patient care in that situation a lot of times. But anywho, so again, make sure you educate the patient, because you can't assume anyone else is going to do it for you. So for instance, here's another example. Say we have a case. Imagine you took your nice otoscope and you saw this, and what are you thinking? Yeah, it looks kind of, looks a little angry, right? Very, very angry tympanic membrane. So we say, okay, we got a 3-year-old. He's presumably left ear pain. We're going to say he's got a fever too. So he's got coughing runny nose. You see that, and you're like, you probably have an acute otitis media. Okay, so diagnosis pretty slam dunk there, right? So now we're going to make a specific diagnosis. So we said, okay, you have acute otitis media. And now we need to describe, okay, well, what do we think is going on here? Do we think this is bacterial? Do we think this is viral? Based on the disease stage, you'll figure out, like, okay, well, if this kind of presentation, they're most likely to be bacterial, right? Versus these kind of presentations, more likely to be viral. In this case, probably going to be bacterial, or the risks are such that you want to hedge on the bets that if it is bacterial, you want to treat it first. So that's kind of the reason why you may do something like that. So then you're going to consider the implications here. So we said, well, we know we have a bacterial infection, but what are the likely bacteria? And you'll learn this in micro, you're going to learn this in pharm as well. We're going to talk about things like what are the most likely bacteria to cause this infection, and we need to pick appropriate antibiotics to cover for that. So we know for things like acute otitis, we know that strep pneumo is a big causative agent for this. We know H. influenzae is a big causative agent for this. So because of that, I want to choose antibiotics that will cover that. I don't need to cover every single other bacteria out there under the sun, because that's too broad. It's going going to cause other problems for the patient. We want to choose as narrow as we can. So this helps us to tailor that antibiotic therapy and prevents us from using kind of our big guns, our kind of, we call it guerrillicillin in some cases, where you're using drugs that basically kill everything under the sun, and it's like you don't need all that, right? Like sometimes we like to not go with the shotgun approach if we can avoid it and just go with like nice precise sniper kind of shot, right? You want to just cover the bugs we want. So anyway, because otherwise you can see things like resistance pop up. And again, you're providing information to the family. Say, well, these are the bugs I think it could be. This is why we're going to prescribe this particular antibiotic. Otherwise, they might come back and like, well, I heard this other one's really good. So you need to be able to say like, well, for these type of infections, that one's really good. But for this type of infection, this is what I want to use instead, right? So then there's lots of good information out there. So if you go to the CDC, they have lots of good info, things about, okay, here's what, the most likely ear infections are going to be. Here's what this sort of thing looks like. Every patient's going to have a phone in their pocket. They can get on the internet, so they can probably look a lot of this stuff up. And then you're also trying to fight patients who are coming in with preconceived notions, right? So everyone comes in, they're like, oh man, WebMD said I have cancer. You probably don't have cancer, but let me check to see if cancer. No, you don't have cancer. Okay, well, WebMD said I might also be having a stroke. You're probably not having a stroke. Okay, but anyway, you can kind of work through all that stuff and be like, well, okay, you read this. Now let me provide you some context to see why, try to clarify and try to address your concerns there. So, nice reputable websites like CDC is really good. Other websites might not be so great. So it just depends on kind of where they're getting their source of information. They know is not a reputable source of information, right? Unless that some guy is a doctor or something. But so anywho, so now you want your objective. Things we want to do for this patient who's got acute otitis. We want to get rid of that bacterial infection, right? So we want to choose antibiotics with appropriate coverage. And we want to also treat the other sequelae of the disease. So for instance, the patient's got fever. So let's try to do something with that inflammatory response. Let's try to maybe give them some antipyretics in order to treat that. We'll look at the patient specifics, look at the age of the patient. We'll assume he has good, healthy organ function, otherwise normal 3-year-old. We'll look at allergies, because allergies can be a big thing that will guide us to choose one antibiotic versus the other. So again, if they already come in with a penicillin allergy, that may preclude us from using a lot of different type of antibiotics. And anytime someone comes in with an allergy, the first question you want to ask them is, what was their reaction, right? So they said, oh, I have a penicillin allergy. And so what was your reaction? I had diarrhea. Not an allergy, right? You can usually rule out 9/10 of allergies based on just asking what reaction did you have. They're like, oh, I got a little dizzy. Nope, not an allergy. Like they said, oh, my throat swelled up and I needed epi. That's an allergy. Okay, you can know not to use that kind of drug. So those are kind of questions you want to ask. And then look at previous or current antibiotics, or just medications in general, but specifically when you're dealing with especially kids or anyone who's on frequent antibiotics, oftentimes that will dictate what type of antibiotics you use for the next infection, because they're probably at risk for having things like resistant bugs anyway. Okay, so again, use all your resources to find appropriate medications in order to treat for this. Now, as far as references, I can't remember which specific stuff you have through your library website, but different references you might be able to use include things like LexiComp. This is our kind of standard one we use at Nemours. It's a very common one. Micromedics, clinical pharmacology, those are all good ones. And then also there are like specific things like infectious disease books. So you guys ever heard the Sanford Guide? This is the Bible for infectious disease. This will be your kind of go-to antibiotic reference. It comes out a new one every year. They have a nice like little pocket-sized one that you can use in your lab coat. I definitely highly recommend at least being familiar with how to use a Sanford Guide, because it will tell you, okay, based on acute otitis media, based on the age of the patient, here's the drug you use. Boom, easy. They have a pneumonia. Here's the drug use. Boom. Here's the likely bugs. It's very easy to use, and so it can be very useful for a lot of providers. The Red Book is one, an infectious disease book we use for a lot of pediatric infectious disease stuff. So you'll kind of figure out, kind of based on the patients you're dealing with, what kind of references are best for you. And then clinical practice guidelines are obviously the best thing to go with if they're available. So for instance, with infectious disease stuff, because again, usually bugs and drugs are like your bread and butter stuff in the clinics or in the ERs. Look at things like the Infectious Disease Society of America. They have specific guidelines put out there. Or because we're dealing with a PEDS patient, look at the American Academy of Pediatrics. They may have specific guidelines for treating those disease states for them, right? So always look up kind of what the most common guidelines are going to be. Are you guys familiar with UpToDate? You guys haven't heard of any of the other ones, but UpToDate you've heard of, right? Okay, UpToDate is pretty good, right? A lot of people use UpToDate as the gospel. That's okay, 99 times out of 100 usually. The one thing I will caution you on, just because I don't get to teach like biostats or anything with you guys, be careful with UpToDate, because they do inject a little bit of their own personal preference in there, right? So you'll see things like, well, we don't really have a good answer for what the best course of treatment is for this particular thing, but at our institution we do this. And people read that and they're like, oh, well, this is what everyone does. No, that's what those people do. And of course, all the stuff's edited. So again, most of the time it's pretty good, and especially if you're just kind of learning up on a new disease state, or if you're trying to, like, the first time you're exposed to something, it's really, really good. But just be careful of that one caveat with use of up to date. Otherwise, it's very good. They also reference all their stuff. So again, you can go and find out, what guidelines were they actually looking at when they made this recommendation. You can double check that stuff. So anywho, so now we need to look at the drug considerations. So how often is a drug given? How easy is it to give drugs to a 3-year-old? Not super easy, right? So you need to consider things like, can I give it one time a day? Or is the patient vomiting so much he can't take oral meds? Like perhaps I can give something intramuscularly or something like that. Those are things you need to consider. Perhaps there are drug shortages. Those are happening all the time, so you may not have access to the things you would normally have access to otherwise. And then look at the cost. Does the patient have insurance? Are they on Medicaid? Are they on, is there any kind of free antibiotic option for them? These are all kind of things you're going to be looking for. And then how palatable is the medication? So again, we mentioned in the PED section, giving drugs to kids is hard. A lot of times we have options for flavoring medications. Stuff I took as a kid was awful, but nowadays we can make it taste like pina colada, practically anything you want it to taste like. I don't know how many kids want pina colada flavored stuff, but my kid loves them. Sleeps great. Just kidding, I don't do that. But anyway, you want to make it palatable for them, so there's a lot of like flavoring options, especially in the pharmacies and whatnot. They can kind of help to make things a little bit better for the kids. Okay, I'm glad I'm putting this online for the police to hear later. Anyway, so looking at the dosage regimens we're going to look for. So this is an example of the acute otitis media guidelines that were taken from, I believe, the IDSA. If not, it was the American Academy of Pediatrics. But basically, you'll see that they have these nice tables they put up, like, okay, here's what the initial treatment recommendations are going to be. Here's what happens if they fail therapy, and they'll have kind of preferred first-line regimens and then alternatives. So you get comfortable kind of looking at these sorts of guidelines because they'll help you to choose, appropriate recommendations for your patients. So in this case, recommended first line for acute otitis, amoxicillin 80 to 90 mg per kilo divided every divide twice a day. Okay, so I know that I can go ahead and give that. If they're allergic, potentially we can talk about using a drug like ceftonir. We'll cover all this in bugs and drugs when we get to pharm, but just be aware these are kind of things you're going to be looking for, right? Once you make your treatment regimen, you're going to decide, okay, I want to use 90 mg per kilo per day divided twice a day for this kid. Amoxicillin comes as a 400 milligram per 5 ml solution, and the kid weighs 20 kilograms. So how much do I give this kid? So we're going to do 20 times 90, right? So that's how much a kid gets per day, right? And then what? 20 by 9. Okay, why do I divide it by 2? Yeah, so again, it's 90 milligrams per kilo per day, but I'm giving it twice a day, so I divide that by 2. So it starts off at 1,800 divided by 2. Now I got what? Who's got the math done with me so far? So did the weight times the dose per day, and then we divided by 2, so we're at 900, right? So 900 milligrams are given per dose, and then based on the concentration, how much did he get? So what I normally do is I take the concentration of the suspension, I divide it out, so I can do 400 divided by 5, and I get 80, right? So then I'll take that 900 divided by 80, and I get, anyone with me? 11.25 mLs. Like, we get 11.25 mLs per dose. You get that twice a day, right? So be comfortable doing those kind of calculations. You can make practice problems for yourself. You can change the weight of the kid, change the dose you want to give, all sorts of things. You can kind of practice with one another and get a good feel for how to do that sort of stuff.
So would it be a bad rationale to do 45 times 20 instead of 90?
You could have. Yeah, just be careful because a lot of times the guidelines will put their recommendations in in a per day dosing.
Right.
So just make sure you're reading that correctly so you can make sure that you are doing the right calculation. Right? Make sure that doing 45 is fine, and it didn't say 90 mg per kilo per dose, right? So just be careful when you're reading that stuff. And it's nice because in a lot of electronic medical record systems, a lot of stuff is defaulted already, right? So you'll have automatic button options for kind of the most common doses, and it does it for you essentially. But it's nice if you ever had to do it on paper, you can do it by hand, right? And again, this is bread and butter kind of stuff you're going to be doing if you're dealing with any PEDS patients, if you're working in ERs or urgent cares. Like, this is kind of easy stuff to do, right? So you just need practice with it. I'm going to put it on the next slide. Wasn't that nice of me to include all the math right there? Fantastic. And more people should have the right answer. You guys could have looked ahead. Oh well. So next, we're going to have a kind of a monitor or devise some sort of monitoring plan for the patient. So again, we're looking for adverse effects. So you're going to see like, okay, if the kid has some diarrhea or if he has a little bit of nausea, that's normal. That's a normal side effect of the drug. We understand that. Try to explain to them, this is why I want you to take this for 10 days because I don't want to have resistant bacteria come back. And then say, what would be an excuse for changing the drug? Kid's on it for 3 days, still has, same or worse symptoms. That may be constituting a change. All those sorts of things you'd want to go ahead and explain, so that way they know, if things are normal or if things are really not normal, they need to come back to you, right? So, and then education plan, either have some like printed education for them, which you can send home with them. Make sure you're addressing educational language barriers and all of that. So any questions on kind of rational prescribing? You guys will get used to this, and you guys will have kind of practice scenarios throughout your didactic time, and then you'll get lots of practice with it in the clinical year, right? So anyway, so prescriptions. What is a prescription? This is a written, verbal, or electronic order from a practitioner to be fulfilled by a pharmacist or a lab or someone else, whoever should be fulfilling these type of prescriptions. So who can prescribe? Some of this may depend on the state that you're working in. It could be the country that you're working in. Obviously, physicians can prescribe. PAs and ARNPs certainly prescribe. Podiatrists, veterinarians. I'll never forget, I had this one order that came in for just an absurd amount of antibiotics. I'm just like, what in the heck could use this much antibiotics? This would kill a person. Like, oh, it's a horse. I'm like, okay, well, that makes sense, optometrists, these are all kind of valid people who should be writing prescriptions, right? So one of the things you have to be careful of is that there are different laws depending if you're looking at the federal level or if you're looking at the state level. So the question is, which one do you follow? Whoever's stricter, right? So for instance, if there's no federal law, but there's a state law, you follow the state law. If there's a federal law that is more strict than the state law, guess what? You follow the federal law, right? Because that is more strict, and so by following the more strict one, you're less likely to get in trouble. Anyone know of like a really good example of one thing where we do not follow the federal law, particular drug? Marijuana is a big one, right? So medical marijuana is huge. Federally, it is still considered, we'll talk about scheduled substances, but it's still a Schedule I substance, right? So it's still a felony to have possession of it federally. Even though in the state we said, hey, this is okay for medical use, assuming you follow these kind of provisions, right? And so that's one case where a lot of states have been going out of the way, but basically the government said, hey, we're not going to pursue these sort of things, right? And so it can depend on a lot of different factors, and this is just kind of one of the things that have been changing over the past decade or so. So again, if I teach this class 10 years from now, who knows? I could be like, now we have recreational marijuana across the entire United States, and everyone is a lot chiller for it. Who knows? I see all those people, and they're just like, hey man, it's growing out of the earth. It's got to be okay. And I was like, cyanide grows in peach pits. Like, you don't eat that. They don't like that argument very much, but that's okay. You cherry pick your stuff. So anyway, so some rules for prescriptions. They need to be legible, and they should be unambiguous. Anyone should be able to read that prescription and know exactly what your intent was and know exactly what you're prescribing. And so basically it helps that you're as unambiguous as possible, so that way other providers can look at that and see like, hey, you actually made an error here, or you forgot to include something or something like that. So that way, because again, all this is a collaborative approach. If a medical error occurs, it's a lot of people's faults, right? Because you guys ever heard of the Swiss cheese model? Right, there's always protections from different errors from occurring, but every once in a while, all those holes of the Swiss cheese are going to line up and an error happens, right? You guys ever heard of a sentinel event? What's a sentinel event? It's like someone dies, someone gets their leg chopped off, the wrong leg chopped off, or something like that. It's a really bad event that either harmed someone or killed someone. And so you're trying to prevent those kind of sentinel events, those kind of medical errors. And a lot of times it happens because the doc did something wrong, and then the nurse didn't catch it, and then the pharmacist didn't catch it, and then whoever else didn't catch it. And it's one of those things where it's just like it's a comedy of errors that occur, and this is why we try to do things as safely as possible. This is why there's so much that goes into things where like only an idiot would make this mistake. The reason why you do that is because some idiot did make that mistake, and now you got to be able to follow this new safety code to do that, right? So anyway, so that's one of the big things we're trying to do is prevent medical errors. So the requirements based on Florida statutes is if you're writing, these are for non-controlled substances, these are for non-narcotic substances, and basically what it says is that it should be written or typed, should be legible. Certainly you can still call in or you can fax in non-controlled prescriptions. So if you need to, if you had a patient call you up and you're on call or something and they needed, refilling their stuff, you can still call it in for the most part for non-controlled substances, and that will be written down, transcribed by the pharmacist. You have to include the name of your practitioner, right? So that's you. The name and the strength of the drug being prescribed. prescribed, so that way we know what to give. The quantity of the drug to dispense, you actually write in the quantity, so if you write for 1 tab a day, you need to write number 30 on there. If you're writing 2 tabs a day, write number 60 on there. And it needs to include the directions for use, so how they should be taking it. It needs to be dated, so you don't want to pre-sign a bunch of prescriptions. You need to actually write it the same day that you actually are writing it there and signing it. And then it needs to be signed by that prescriber. It doesn't have to be a handwritten signature. It can be like a stamp. You can have electronic signatures. Like a lot of things are being accepted nowadays. And again, non-controlled prescriptions. And then, of course, they can be called in or communicated electronically. And the other big thing to know is that all non-controlled prescriptions are good for 1 year. So even if you write for amoxicillin, I'm going to give you infinite refills. I'm just going to write an infinity symbol on there. Guess what? After a year, that prescription is no good anymore. Okay, you would never do that in the first place. But they're like, okay, I'm going to write you an antihypertensive, and I never want to see you again in my office. 99 refills. See you later. And that's not going to go, right? It doesn't fly past 1 year. So just be aware of that. You can write for multiple scripts on the same piece of paper. That's totally fine. We like to keep controlled substances off of those same other scripts because, again, those get filed differently, and there's other regulations that go along with those. And then very specifically, C2s, we'll talk about controlled substances in a second, but C2s are the most controlled, essentially, and these have to be by themselves because they get handled very differently from other types of prescriptions. So here's an example of a prescription. I'm sure you guys have seen them all here. A lot of times you'll find that these are going to be pre-done with a lot of your information. So it'll have like the prescriber's name, it'll have their license number, the DEA number. You guys know what the DEA number is for? Yeah, for controlled substances, right? So this makes sure that you're validated, you're authorized by the DEA, the Drug Enforcement Agency, to prescribe controlled substances. And then you also have your NPI number. These are all good because we can look up your information from the pharmacy, make sure that you're actually a valid prescriber. And usually you'll have a lot of your information on, like your phone number and address. Name of the patient, date of birth, usually the date. Notice that some of this stuff was not included on the requirements for a prescription, but this is still just nice to have information. So you don't have to write the date of birth of the patient, but it's good to have that on there so that way we know, there's not 4 other Sean Martins in our system. We can make sure we're actually doing the right one that it was born in 1972. So you have the name of the medication, the strength of it, and then what is this right here? That's the brand name, right? Do you have to include the brand name? You don't have to. Sometimes it's fine to have it on there, but and even if you wrote for the brand name, would we fill it with the brand name? Not necessarily. If the only thing that's available is the brand, then yeah, certainly we'll fill it with that. But by law, one of the things we do to save money for patients is by law, if you wrote for a brand name substance, pharmacies will switch it out for the generic, right? Because we've shown they're bioequivalent, we've shown they have the same kind of efficacy and safety characteristics, we can switch that out. There's a small list of things we can't do that for. It's beyond our scope. But there's one thing you can write on there that makes sure you get whatever you write on there as far as the brand name goes. And it's a DAW, or dispense as written. If you write that and write the brand name, we have to fill it with the brand name. So that's part of the law on our side, is that we make sure we fill that appropriately. So basically write the quantity, so you get number 100, and they do take 1 tab daily for controlled diabetes, and they have 3 refills, right? And then they sign at the bottom.
Yeah, you talk about running like 30 for 1 pill per day or 60 for twice a day. So what do you put in here?
So basically, in this case, they would be filling for roughly 3 months worth, right? And yeah, sometimes people write for 100 just in case like they lose one, or the dog eats one, or something like that. A lot of times though, you'll find that insurances may only pay for 90, right? So it depends on kind of what their limits are. And so if we try to run it for 100 and the insurance comes back and they reject it and they say, hey, we can only fill 90, we'd change that over to 90. We'd still include that 10 in the balance for the whole prescription, so we'd include in those refills, but we'd only be able to fill what the patient's insurance would cover, because they don't want to pay out of pocket for that sort of thing if they don't have to, right? Again, putting the refills on there. If you put no refills there, then we just assume there's none, right? Okay, so some prescribing errors. A lot of times it's due to omission of information. So we try to avoid these whenever we can. But things like, continue present IV fluids. Well, if the person doesn't know what those IV fluids were, then they don't know what to continue necessarily. Or resume pre-op meds. Well, did you actually want every single pre-op med that was on that list? Perhaps the surgery has changed something with the patient where you don't want to use certain medications anymore. You want to add new ones on. So make sure these prescriptions that you're going to write will be very, very specific. A lot of errors come about when they fail to discontinue prior meds when they start a new one. So oftentimes patients will, and we do these brown bag events when we volunteered in pharmacy school, where you go to these nursing homes and patients bring all their meds and they have like 30 different bottles bottles from like 1980 on through current day, and it'd be like, well, are you still taking this one? And it was like, yeah, I guess so, but like, it expired a long time ago. It was probably discontinued, but they never got the message essentially. So make sure that they know to discontinue meds when they're supposed to. If you don't indicate between short-acting and long-acting, that could be a potential source for error, especially if you, write for something, say, twice a day and it gets misfilled with the immediate release instead of extended release. That could lead to some issues that happens there. And then the other big thing that, especially if you guys ever heard of Joint Commission. So Joint Commission is a major accreditor of hospitals, and so basically if you don't get accredited by Joint Commission, you don't get like your funding from like Medicaid and Medicare and all those places. So hospitals are very much incentivized to pass Joint Commission accreditation. One of the big things that we got hit with, or not hit with, but one of the things we were working on was this kind of as needed basis, right? So if you write PRN on a prescription, what does that mean? As needed, right? So you have to include what as needed means, right? So as needed for pain or as needed for cough, because otherwise it's ambiguous, right? The patient may not understand when to take it, or if you have multiple drugs. So say, for instance, you have like an NSAID, like ibuprofen, and then you have something like hydrocodone on there, and they both say PRN pain. Well, the nurse is taking care of that patient, and they need some kind of indication on which one to pick. Otherwise, they're independently prescribing at that point. That's the Joint Commission's view. And so nurses, as great as they are, and as well as they could probably make that decision on which med to give, that's outside of their scope of practice. So you have to say, give the ibuprofen as needed for pain, and then you give the hydrocodone as needed for pain if ibuprofen is ineffective, or some other indication show that they use one then the other, or based on pain scale. So on a pain scale 1 through 5 you use ibuprofen, 6 through 10 you're going to use hydrocodone. You have to be very specific about these sort of things to make sure the patient gets exactly what you want. So and again, don't write prescriptions like this. Again, most of the time you're going to write them nowadays, it's going to be electronics. You don't necessarily have to worry about this too much, but if you're going to write it, please be very specific, because otherwise you have to make heads or tails of that, and you don't want us to have to call you, right? That's the main goal in your life should be not to get phone calls from the annoying pharmacist, especially in the middle of the night. You don't want that. So write legibly. You guys mind if I finish up? I don't think I have too much left. Okay, so other kind of prescribing errors. So one thing, having misplaced decimals. So if you are trying to write for something that's 0.1, a lot of times that can be misread as just 1, right? So then you have a tenfold dosing error that happens there. So you always want to precede decimal points by 0 whenever you can, okay? On the flip side of that, you don't want unnecessary zeros after the decimal. So if I were to write 1.0, that can be misread as 10. Not good. So again, if there's anything or nothing after the decimal, then don't put anything. If it's 1.05, then you can write that, but 1.0, don't do that. And then misreading U as a 0. So for instance, U normally stands for, usually stands for unit, so insulin is the most common thing you'll use that for. So for instance, if you read 10 U of insulin, that could be misread as 100 units of insulin. You imagine like who can misread that, but you'd be surprised, especially if it's handwritten, that it could be misread in some scenarios. So again, always write out the word unit. So again, always write out as much as you can, because that helps to avoid a lot of those kind of errors of abbreviation. Other things, so if you were to misread micrograms as milligrams, that could be a 1,000-fold dosing error. That would not be good for most patients. So again, we use things like MCG. That's going to be less likely to be confused, right? So it's easier to see the difference between that and MCG. This is a big one we don't use anymore. So if you're here, like take 1 tab QD. QD sometimes can get misread as something like QID. So that's why we don't use that anymore. So just write out daily, right? So it's easier just to write that out and you don't have to worry about it. So, instead of getting it 4 times a day, they just want to get it 1 time a day. And then this is kind of an older error. We don't really do this anymore, but not writing out full drug names. Back in the day, morphine sulfate used to get abbreviated as MSO4, and that would get confused with magnesium sulfate, MgSO4. So again, you're thinking, man, the patient's magnesium is low, and they get a drug, and all of a sudden they feel great, right? Like, probably not exactly what you intended, right? So that's why we don't use those. We use the full drug names whenever possible. Yes?
About when you're writing daily, so I get for if it's 1 time daily, but they're still using like BID and things like that. So what is it just the ones daily that
it was just like QD.
The other ones you can use
Yeah, so BID, TID is still used pretty frequently. It's just like QD that was the one that was getting misread most frequently. Because again, most drugs are given once daily, and so it was just the most common error they were running into. Other things, if you don't include the strength and the dosage form, we actually had some errors where medication reconciliation is a huge problem in a lot of hospitals, to where patient comes in and the nurse will say, well, what meds are you taking? Nurse will just kind of pick the first thing on the list, and it may not always be the most accurate thing. And so we actually had one error where a patient could have gotten a 5 or 10-fold overdose of a different different drug based on the concentration that the nurse had picked out of the list was different than what it was actually taking, and it led to a much different dose than what they should have been on. So be careful with that. And never, ever, ever write in teaspoons or tablespoons. Only write in mLs. Right? That's kind of the standard that we're doing nowadays. Make sure you include the quantity of drug. That way it makes sense based on your order. So if you write for take 1 tab twice a day, and you write for number 30, that's probably going to get you a phone call, right? Because we're going to be like, are you sure you didn't mean 60 that you wanted to fill for that? That makes more sense based on what you wrote, right? And then we mentioned that dispense is written there. Have to write it if you do not want your stuff substituted. And there's just a list of different things that can be misread. So these are kind of like unapproved abbreviations. You can see how they can get mixed up as other things. Some of these, again, you're like, who could mix this up? Someone's mixed it up, and that's why it's on this list. Okay, so do not, discount the ability for people to make dumb mistakes. Right, we're all human, and so it's all very, very possible for it to occur. So. All right. Other types of things, typically do not write use as directed, especially if the patient doesn't have a very good memory. They may not know exactly what that means. Usually that's okay if it's something like it comes in a dose pack. So this is a methylprednisolone dose pack. This one's very explicit, right? You take all these pills on the first day, you take all these pills on the second day, third, fourth, fifth, sixth day. That's pretty obvious, right? You can write dispense as written, right? Or use as directed. But for things like, take 1 tab twice a day, like just write that out, instead of assuming that the patient's going to remember what you'd wanted, right? Be careful with drugs that come in different forms. So this is a really good example of something we use in the hospital very frequently. So especially like in a code situation where patients actively dying or dead, we're trying to resuscitate them. Calcium is something that gets given pretty frequently, and there's 2 forms of it that's available. There's calcium gluconate and calcium chloride. They both come as a 10% solution. They both come in a 10 ml vial. But the big difference here is that calcium gluconate has about 1/3 of the actual calcium calcium chloride has. Why is that? Because gluconate's a lot bigger than chloride, right? So because of that, this has about 3 times the amount of elemental calcium. So if you say, give an amp of calcium, first off, what's an amp mean? You ever seen like a little ampoule you have to break the glass top off of? Like, we don't really use a ton of those anymore. So again, it's inaccurate for one to call it an amp. But then the other thing is like, well, okay, do you want calcium gluconate? Do you want calcium chloride? Like, what specific one do you want? So don't always assume that everyone is going to be on the same page as you, especially for an emergent situation. If you're yelling things out, assume that you need to be as specific as possible. So say, I want 10 mLs of calcium chloride in this patient's stat. That would be much more specific and much more likely to get the exact thing the patient wants, or that you want to give them. Another good example of this is a given amp of bicarb, right? We have 2 concentrations of bicarb. One's this 8.4% that we use for adults, and one's 4.2% we use for kids. The concentration is about half, right? So they say give an amp of one versus the other, that can change your dose pretty significantly, right? So you want to make sure, especially if they want bicarb, like you want them to get the right amount. Again, be specific with your unit. So for instance, if you're starting a drip of something like dopamine, start the patient on 20 of dopamine. Well, 20 what? 20 micrograms per kilo per minute? You want milligrams per minute? 20 ducks? Like, what do you want? Like, you need to be very specific with that sort of thing. Because I've seen whole bottles of a drug get infused to a patient within minutes because they meant to do milligrams per minute, and they did milligrams per kilo per minute, right? Patient weighs 100 kilos, the drug's going in 100 times faster than what you expected it to. So be very specific with that, and that's where a lot of things like pump libraries, things like that can be very useful because it kind of limits what the nurses can program into the pumps there. And then just be aware of, other reasons for common drug errors. Be aware of contraindications or drug interactions that occur. Make sure you get a full med list, including herbals and OTCs, because you can miss big important interactions. I had one patient who came in with a massive head bleed and ended up dying because she was on warfarin and thought she wanted to take some ginkgo for her memory, and didn't realize that ginkgo can cause antiplatelet effects. So they ended up having a massive bleed and died. Right, so those are kind of things you want to be cognizant of. Ask your patients about whether you think they work or they don't work. It doesn't really matter. You need to let your patient be forthcoming with you, and you need to have the full picture though to make good decisions. Be aware of incompatibilities between drugs. This is especially important for things going in IVs. If they're physically incompatible, that can cause an embolus and hurt a patient. And then be aware of any kind of disease state interaction. So, if, for instance, if they're diabetic, you give them a steroid, it's going to drive their blood sugar up, right? You need to be aware of those kind of things prior to prescribing, so make sure that you can at least account for them when they do happen, or you can do something to avoid it, right? So, actually, how many more slides do I have? Does anyone know? 10 more. Do you guys want me to finish or record it? Finished? Okay. So just real quick for compliance, so again, also known as adherence, this is how well your patient is going to follow your instructions. There's 4 basic types of non-compliance. There's one where they fail to obtain the medication, so if they don't have money for it, they're not going to get it, or if they don't think it was going to work, they're not going to get it. They fail to take the medication as prescribed, either intentionally or unintentionally, right? So sometimes they're like, well, I only have enough money to get this every other month, so I'm going to take a pill every other day rather than one time a day, stuff like that. If they prematurely discontinue the medication, so they say, man, this medication makes me feel like crap, I'm going to stop taking it, and then they come back in to see you, and they're like, oh, how's the medication going? They're like, oh, it's fine. They're not taking it, right? Those are things you need to worry about. And if they're taking it inappropriately, so they misunderstood the directions, or they're taking it not appropriately, those are things you can figure out as well. About a third of patients never have their actual prescriptions filled, either due to cost or some other reasons. I can't tell you, working at a retail pharmacy, how many people come up from the ER, they have a prescription for Lortab or Percocet and an antibiotic for their toothache. And they're like, just give me the Percocet. And I'm like, you sure you don't want the antibiotic? Nope, don't want the antibiotic. And I'm like, fine. Do it anyway. We're not happy about it. So sometimes people are gaming the system a little bit. A lot of pill seekers. But also, there could be difficulty finding the product, especially if it's something that's not super common or something that has to be compounded. That can be tough. Or if you're writing for, something, they come to visit you in the ER in the middle of the night. There's no 24-hour pharmacies. That can be problematic as well. So a lot of times we'll get them started like on a single dose in the office or in the ER to try to get them on the right track. And then they just have a lack of perception for that need of the medication. They're like, well, why do I need to take this? I feel fine. My blood pressure, I don't feel like I have high blood pressure. I'm probably fine. Obviously this, an education point you can make with them. It's like you don't feel the hypertension now, but you're going to feel the heart attack later, right? So I tell them. Anyway, so the patient fails to take the medication as prescribed. It could be due to either wrong dosage, if they're taking the wrong frequency, the wrong route. I've certain patients who, there's an inhaler called Spiriva. They use it for some of our COPD patients, and it comes in a little capsule, and it goes in this specific inhaler, and it has a little button, you puncture it, and then the powder comes out and they'll inhale it. And I can't tell you how many calls at the poison center, these old men who called, and they'd be like, hey, I accidentally swallowed my Spiriva capsule because I took it with all of my other pills. And I'm like, okay, you're going to be fine. You're not going to die from that. Like, oh, good, thank goodness. Like, but they're also not getting their medication for their COPD, right? So those are things you have to worry about. They have a wrong technique of administration. Think about trying to use an inhaler. I don't know if any of you have asthma or have ever used an inhaler, but try using that. Imagine having osteoarthritis or rheumatoid arthritis and trying to be able to coordinate that sort of thing. So technique can be a tough thing, or if they're having to inject themselves subcutaneously, very, very difficult in some cases. To make sure they have if they didn't get good communication or they have understanding of instructions, that's where language barriers can play a big role. So you gotta be careful with that. And just imagine, try to you can try this, with people but say take 2 tabs by mouth twice a daily. What does that mean to any of you? Yeah, so should I take a pill in the morning and take a pill at night to get 2 tabs per day, or should I take 2 in the morning or 2 at night? It can be very difficult, even if you have the best medical understanding in some cases. So this is why we do kind of that teach back method to say, okay, well, what are you going to do when you go home? I'm going to take 2 tabs in the morning, 2 tabs at night. You say, great, you got it. That way you can kind of catch those kind of errors before they occur. So if patients prematurely discontinue their medication, a lot of that happens with antibiotics. So they feel like I'm getting better, it must be past the infection. They don't take but 3 days of a 7-day course. Or if they finish the bottle and say, all right, I'm all done with it, and they didn't realize there's refills on it. They're supposed to keep taking that medication for a long time. And then if they don't perceive there's any kind of benefit, they probably if they don't feel any different, anything like that, or they have side effects, it may lead them to stop early. So a really good example is antidepressants. Antidepressants take at least 4 to 6 weeks before they really start to kick in. So you give it to a depressed patient, they're already kind of upset to begin with, and they're like, well, I've taken this for 2 or 3 weeks, all it's caused is side effects, and I don't feel any better. That's going to lead them to stop taking it, unless you kind of educate them beforehand and say, hey, it takes time, 4 to 6 weeks, and then we'll come back and check to see what's going on. So, and if they're taking it inappropriately, sometimes you'll have patients that share medications with others. Say, hey, Ethel, you have a UTI. I took this stuff last week, got a really good effect from it. Here, you're going to take the rest of my stuff. Not appropriate, right? Medication abuse too, if people start self-dosing for whatever reason it happens to be, whether incomplete pain management or otherwise, that can also be a reason for them to inappropriately take their meds. So. Okay, so just be aware patients will do all kinds of weird things, but again, try to be as curious as possible. Don't try to come down as judgmental. Just say, hey, if you're taking it incorrectly, if you're not taking it all, that's fine. Just let me know so we can make sure we can have a good conversation and try to come up with the best plan for you. But anyway, for controlled substances, these are drugs with a perceived potential for abuse, and this is all dictated by the DEA, or the Drug Enforcement Agency. And so we have the Controlled Drug Act that kind of set up to say what these different schedules are. And so for writing a controlled prescription, the DEA number for the prescriber has to be on there. That way we can back check it and make sure that it actually is appropriate. There's 5 schedules. Schedule 1 is the highest, meaning has a very high abuse potential, and there's no acceptable medical use. Okay, so like marijuana falls in this category. Things like ecstasy fall in this category. Things like heroin are in this category. Schedule 2 still have a high abuse potential, but they do have an acceptable medical use. So who knew that cocaine was a Schedule 2 substance? Absolutely. We used to carry cocaine over at Nemours because you can use it for some ENT procedures because it actually has good anesthetic properties. It's vasoconstrictive. Lots of good reasons to use it. We don't carry it anymore. But basically, that's still considered having medical use. That's kind of the two differences there. 3, 4s, and 5s, they are diminishing levels of abuse potential, and they all have acceptable medical uses. So these get regulated less tightly than your C2s. And C1s are that's a felony to have basically, unless you have the kind of the appropriate research paperwork and things like that to have. You guys ever seen the movie Half Baked? If anyone's ever seen that, when Dave Chappelle, he goes to the counter and he goes to hands the thing over to get the marijuana, it comes like a big box of it. Like, it's not quite like that, but I imagine I'd probably feel the same way if they just handed me that stuff and I'd be like, I feel so illegal. But some people can do some research with it, but it's pretty rare. So states will have their own Schedule 1 substance list. So you can have, just recently, like Florida put a ton, a couple years ago, we put a ton of stuff on there to combat things like synthetic marijuanas and bath salts and things like that. So you'll find this list will change over time. But additional requirements for a prescription, you have to have the full name and address of the patient, or if it's an animal, you have to put the owner that's on there. Sometimes animals will be on controlled substances, usually it's like phenobarbital for seizures or something like that, so that's probably the most common one I run into. And then for the animal, you have to specify what the species is. Some of your patients may be animals, but you don't have to write down human on there. Just kidding. And then you have the full name and the address for the prescribing practitioner along with the DEA number. If that's not on there, it's not considered valid. And then you have to have the written and numerical numbers. So you have to write 20 in numbers and then in letters as well to make sure we know exactly how many we're going to be prescribing. Now, Schedule 2 substances cannot be refilled, so it doesn't matter if you put 10 refills on there, we're never going to refill it because it's a Schedule 2 substance. However, you can write for up to a 90-day supply. So think about things like your ADHD medications. A lot of those are amphetamine-based, and a lot of those are Schedule 2s. So instead of them having to come back to you every single month for a new prescription, you can at least write for 90 days worth. And what some prescribers will do is they'll write for, say this one did be filled on July 25th, this one be filled, do not fill until August 25th, and this one do not fill until September 25th. And we'll usually honor those kind of prescriptions. We'll let the patients hold on to them because we don't want to hold on to their prescription and they come back and say, well, I handed it to you, and we'll say, no, you didn't, we don't have it, and then it's bad news. So we don't like to do that. It also has to be written on tamper-evident paper. So it's that kind of paper where if you copy it, it says copy, void, all those kind of things on there. So and you have to get the paper specifically from different vendors who are registered with the DEA. That way you don't have people with kind of erroneous prescriptions out there just filling it for whatever they want and taking it to the pharmacies. And these cannot be transmitted over the phone, so you have to bring an actual paper prescription in. Okay. The only thing different with that, with 3s, 4s, and 5s, is they can be refilled, and you can do a maximum of 5 refills, so a total of 6 months of drug can be administered for that. You can also, these do not have to be on the paper necessarily. Some of these can be called in some cases, and so, but most of the time people will still put them on paper anyway. Again, here's an example of that counterfeit proof paper. Again, it would be very obvious if someone has copied this and trying to take it to multiple pharmacies. We would see that and say, no go, we're not going to fill that. That's our prerogative. So again, so just real quick quiz. What schedule do you think morphine is? 2, yes, that's 2, so very highly controlled. Cocaine I mentioned is already a 2. How about methamphetamine? It's actually a 1. There's lots of amphetamines that are Schedule 2 that we use for ADHD meds, but methamphetamine itself is actually 1. And the marijuana, Schedule 1 still federally. So again, yeah, still federally considered to be a Schedule 1 substance, a felony to own. Even though, I mean, you can, if you have a medical marijuana license in DC, you can still go in front of the White House, smoke up, and you're totally fine. If you have the appropriate paperwork and whatnot. So kind of cognitive dissonance at work there. So anywho, some states you'll find there's different controlled substance rules. So there's a drug called carisoprodol. The brand name is Soma. Because we saw more abuse for it, Florida actually made it a Schedule 4 substance, and a lot of other states it is not. So you'll find some certain state to state kind of differences there. And then there's been some recent changes over time based on abuse noted abuse of different drugs. So for instance, tramadol is kind of a wimpy opioid. It used to be unscheduled, but now it's a Schedule 4 because people were abusing it kind of rampantly because it couldn't get a hold of a lot of other stuff. And then hydrocodone used to be C3, now it's C2, which makes it much more difficult to get a hold of. It's handled the same as oxycodone is now. So, but it's interesting. We've definitely been seeing, hydrocodone used to be at the top of the list as far as #1 prescribed drugs every year. Now you're starting to see it kind of take a hit a little bit, and you're also starting to see deaths from heroin in the state actually starting to go up in response to a lot of this, because prescription drug abuse was huge here for a while. We were definitely the first stop on the OxyContin highway, right? If you guys ever heard of that, OxyContin Express, like we were the main place where they were filling that and taking it back up to Kentucky and Virginia. So now that's starting to take a hit quite a bit because it is much more difficult to get a hold of hydrocodone nowadays. So, any questions on any of that stuff? Sorry I went over a little bit, but we'll do the review next time, and then you guys will have the test. All right, see you next time.